She was just 2 weeks ago brought on as the research director of UCLA's Cannabis Research Initiative. And you may also know her name from the report that was referenced this morning that was put out in 2017. She was on the National Academy of Sciences Committee on the Health Effects of Cannabis. And so with that, I'd like to introduce to you Ziva Cooper and Rosalie Pacula.
Thanks to everybody who stuck it out. Is that on? There we go. We are very excited to be here. I arm roped Ziva when I saw her yesterday to participate in this particular session because I think her expertise is far superior than mine on a couple of the questions that need to be addressed when you're talking about the impact, the potential impact of cannabis on the opioid epidemic. So she wasn't in the program, but I roped her into it, and she's so kind to actually join us to do this.
And it's an honor to be on stage with Rosalie Pacula, so I'd like to thank her very much.
Another reason why I invited her. I needed a fan. So, if you've opened the newspaper in the last couple weeks, you've heard we're having this opioid crisis. And for those of you who might have been avoiding the newspapers because of the horrible news that seems to come out of them, let me give you just a flavor of what we mean when we talk about the opioid crisis. Today, the latest data, there are about 191 million prescriptions for opioids written just last year, according to most recent data. That's about 17% of the US population that's getting an opioid. And on average, of those who are getting an opioid, they're getting about 3.5 opioids a year. In addition, we have about 11.5 million Americans who are using prescription opioids non-medically for not as intended by the doctor. There are at least 1 million individuals who also, based on self-reported household data, use heroin or have heroin dependence. And I say at least because we know the household population is not really the place where you look for the heroin-dependent individuals. And then there's, sorry about that, about 2.1 million Americans who suffer from opioid abuse or dependence. And this has been actually fairly stable, unfortunately, for the past several years. Those are the numbers of the drugs and the users, but what makes it into the newspaper most often are the statistics on the opioid-related mortality, which, compared to prior drug epidemics that we've had historically, far exceeds anything we've seen in any other drug epidemic. And unfortunately, it's continuing to increase. In just the last year, from 2016 to 2017, there was another 10% rise in drug overdose mortality, driven largely by illicit fentanyl. So this is an enormous problem. But to understand the epidemic and what these numbers really mean, you need to put it within the context of the dynamics of use and the stocks and flows of users at different stages of use. That's how we like to think about it at our end. So to do that, we need to start with the new users, people who are getting introduced to opioids. And I'm giving you this context because it's with this context that we would like to have a conversation of the utility of cannabis for solving the epidemic. So by new user, I mean somebody who is opioid naive, never had an opioid prescription before, didn't need one, having surgery or emergency medical condition, or something happened, they broke an arm and they need a painkiller. So new users are individuals who can get introduced medically, but it's also individuals who can get introduced recreationally, teenagers at a party, having a pill party with a bunch of pills and put in the middle of the room, and they grab one that just happened to have some hydrocodone mixed in the mix. These are occasional users. Then there's the group, the stock of users in the community who are those at risk of a real serious negative side effect, including dependence. They're at risk of it. These are individuals who are using their medication above the recommended levels or for longer duration than required. These are people who are at risk, as well as individuals who are transitioning from, say, a prescribed opioid to an illicit opioid because they no longer have access to a prescribed opioid, and so they'd rather go to the black market to get the drug. These are users we think that are most at risk of escalating into abuse and dependence. Dependent users are those, by the definition that we're using because of our ability to measure it, people who generally meet DSM-4 type criteria for abuse and dependence. And users all along the spectrum, each of these stocks of users can, in some ways, experience an opioid-related harm. Even a naive user can experience an opioid-related harm. And the opioid epidemic is really about this whole dynamic of users, the transition from the first initiation into the at-risk user to dependent user and the harms that they impose. And the question that we want to ask this afternoon is, what is the role of cannabis in light of the dynamics of this opioid crisis that we're experiencing today? If you look at the popular press, Scientific American, Time Magazine, there's a general belief, and we've heard it even at the conference, that cannabis might be a real viable way of tackling this opioid epidemic. And I think what we'll describe to you is, while the science is clear, there's aspects that it might be helpful with. It's not yet, the science is not yet clear that this is a silver bullet for tackling the epidemic. Let us try to convince you where we think it can be helpful and why it's not going to necessarily solve the problem. I'm going to hand it first to Ziva for this first one.
Great, thanks so much. So one way that cannabis and cannabinoids might help to mitigate the opioid risk is perhaps if cannabis can be used as a pain reliever, as a substitute to opioids for pain. So we concluded, the National Academies of Sciences concluded, that there was substantial evidence to indicate that cannabis and cannabinoids may be effective specifically for chronic pain management. So note that the evidence was not just based on cannabis. A lot of the evidence is actually based on cannabinoids, the chemical constituents of the cannabis plant. And this is specifically for chronic pain. There wasn't enough data out there, there weren't enough studies to demonstrate that cannabis or cannabinoids can actually be useful for acute pain. There are only about 6 studies that have looked at it thus far. The bulk of the studies, about 40 randomized controlled trials, have actually looked relative to placebo, can cannabis and cannabinoids be helpful for certain chronic pain conditions? And there seems to be substantial evidence that supports this. There's pharmacological and physiological evidence that also supports the therapeutic mechanisms for the utility of cannabis and cannabinoids for pain. This has been shown elegantly in preclinical research, and we're now starting to see burgeoning literature demonstrating that cannabinoids may be helpful for certain chronic pain conditions. And it should be noted, and a lot of us have already heard this today, that patients, medical cannabis users, overwhelmingly report that the primary indication for which they're using medical cannabis is pain. And these medical cannabis users are reporting that it is helpful. So we have evidence from randomized controlled, placebo-controlled trials indicating that cannabinoids, and in some cases cannabis, might be helpful for chronic pain. And we also have these subjective reports indicating that medical cannabis has been helpful for people who are seeking out cannabis to help with their pain.
So what does the epidemiological and ecological literature say about this? Well, some economists, dad and daughter team, have done a series of studies looking in Medicare and Medicaid data that have been replicated by Igor Grant and Yun Shi, who's here in the audience as well, identifying that states that have medicalized marijuana have indeed shown lower rates of prescription for opioids after the medical marijuana stores opened. And in the case of the Igor Grant and Yun Shi team, they actually showed the same thing for legal cannabis. And that suggests that what the impact of cannabis on pain might actually be pretty valuable. Keep in mind, I was talking initially about initial pain. That's important for a couple of reasons. First, while the prescription drug data does suggest a decline in the amount of opioids being prescribed in states that have adopted medical cannabis programs, the opioid distribution data that is reported through the DEA does not show the same declines in the amount distributed to states. In a study that I did with my colleague David Powell, where we also find an impact on opioid-related harm, we see no impact of medical marijuana on the amounts of opioids distributed to hospitals, pharmacies, and doctors in states that have adopted medical marijuana policy. So that's a little bit of a conundrum. We're seeing in the claims data a decline, but we're seeing in the distribution data no change. There's a question that needs to be answered there. But it's also important to keep in mind, if we're talking about tackling the new users, then we need to think about the first condition for which people are getting the opioids. And in the recent studies that have been done, looking at the opioid-naive patients, the first opioid use is largely for a surgical procedure, sometimes a dental surgical procedure, but a medical emergency. And these are doctors that are not real likely to prescribe cannabis in lieu of an opioid for acute pain. So in the case of tackling new initiates in the medical market, I think it's unlikely that I'm not going to attribute this to Ziva, I think it's unlikely that cannabis is going to reduce new initiates for medical purposes. Might reduce the amount that's sitting in the medicine cabinet for the recreational user, but it's not clear because of that distribution of opioids is not affected in medical marijuana states. I'll come back to that conundrum in a minute. We're going to go to at-risk use next.
So circling back to the question, is there evidence that cannabis and cannabinoids can actually substitute for opioids for pain relief? Okay, so this is one of the primary areas that cannabis might actually be helpful in reducing our reliance on opioids, is can it actually substitute for opioids for pain? Now, if you look at the randomized controlled trials, we actually don't have very much data to hang our hat on. There's one study that looked at nabilone, which is a drug that's very similar to THC, the primary psychoactive component of cannabis, and compared that to an opioid for various chronic pain conditions. And the results were not positive. Apart from that one study, we actually don't know. We don't have data comparing opioids to cannabis or cannabinoids to demonstrate that cannabinoids might be a suitable substitute for opioids. The next question is, can cannabis or cannabinoids be an adjunct to opioids? Might it be the case that when you add cannabis or cannabinoids to opioids, you need a lower dose of the opioid to achieve the pain relief that you need in order to get through your day? And importantly, if cannabis and cannabinoids can reduce the opioid dose needed for pain relief, do you also see a reduction in the adverse effects of opioids that are devastating our current public health situation, right? So this is very important. We need to know, can cannabinoids increase the pain relieving effects of the opioids so that you need a lower dose, but in doing so, does it also not increase the adverse effects? And so we did a placebo-controlled double-blind study, the first of its kind, where we actually looked at combinations of cannabis and various doses of an opioid in order to see, can we push that dose of the opioid needed for pain relief? And what we found, this was a study that was actually done in healthy controls, and we looked at their pain response using a laboratory pain test. And we did find that when you combine cannabis with a low dose of an opioid that is not pain relieving on its own, you actually produce robust pain relief. Now, these results were very encouraging, and they actually reflect what we see in the animal literature, where you can see what we call a synergistic effect of THC and THC-like molecules with opioids, such that you can combine the two chemicals at a dose where they don't have pain relieving effects on their own, but when you combine them, you get synergistic pain relief. And in those animal models, you get that robust pain relief, but you don't get an increase in the adverse effects, like an increase in the rewarding effect of the opioids, which is really important. So when we think about the utility of combining cannabis and cannabinoids with opioids, again, we want to make sure that we're not going to see an increase in the adverse effects of opioids. So what do we see? We actually see that there might be some hint that the cannabis might increase the abuse liability, the addictive potential of the opioids. But it's modest, and it's a hint right now, and we have a grant right now to actually look at this further. Is it actually true that when you combine cannabis with a very low dose of an opioid, do you also increase the abuse potential alongside its analgesic potential? This is a critical question to ask. I want to say that one aspect of the potential utility of cannabis and cannabinoids to help curb the opioid epidemic is understanding the potential for these chemical entities, these cannabinoids, to somehow reduce the degree of dependence that people experience when they're taking opioids, or to reduce the potential tolerance that sometimes leads to increasing doses of opioids. And this has been a hope. There's evidence in, again, the preclinical literature and animal models that does suggest that when you add cannabinoids to opioids, you can actually decrease the rate of tolerance that develops. We have not yet seen this in human studies, and this is also an area that is extremely important to pursue in order for us to understand if cannabis and cannabinoids can potentially be an adjunct to opioids for pain relief. There is some evidence, when we look at epidemiological data, there is some evidence that cannabis can reduce at-risk opioid use in the general population. And based on these observational studies, it suggests that in populations that are using cannabis, they're at less risk of opioid use-related harms. In fact, I was just at an excellent session earlier today with Dr. M.J. Malloy, and he presented really nice data showing that in at-risk youth, the at-risk youth who were using cannabis were less likely to engage in injection drug use later on. And so that's an example of how cannabis might help to curtail risky opioid use in the future. Also looking at other studies that can demonstrate that cannabis and cannabinoids might help to curb this epidemic, this opioid epidemic, when we're looking at dependent individuals. So we've already talked about how cannabis and cannabinoids might help with pain. And we now want to know, can it actually help with opioid use disorders? So there's nice data that demonstrates that cannabis use, this is observational data, that cannabis use can actually improve retention in studies of medications for opioid use disorders. So this has been shown with agonist replacement therapies such as methadone. It's also been shown with antagonists such as naltrexone. There's been mixed findings related to the impact of cannabis and cannabinoids on opiate withdrawal. So one hope, and one thing that we hear frequently in the media and based on patient self-report, is that people are using cannabis and it really helps with opioid withdrawal. So there is self-report data where we can see that cannabis might have some effect on opioid withdrawal, and we see this in the preclinical literature as well. THC reduces opioid withdrawal symptoms in animal models of opioid use. However, when you look at the randomized controlled trials, we don't really have a strong hint of that, but only a handful of these studies have been done. Only a handful of studies, 2 or 3, have been done actually looking at THC, the primary psychoactive component of cannabis, on opioid withdrawal. So more data needs to be done with regards to that endpoint as well. And it's also unclear if cannabis and cannabinoids actually can reduce drug use, opioid drug use. So once people are have decided to stop using opioids, can cannabis help them to decrease rates of relapse? And the truth is, we don't know. There's one study with a small sample size that actually looked at cannabidiol. Cannabidiol is a non-intoxicating component of the cannabis plant that we heard a little bit about today, earlier by Dr. Graham. And there's one study that showed that cannabidiol helps to reduce craving in heroin-dependent individuals. So there's that one study, that one randomized controlled study, that does indicate that perhaps cannabinoids might help to decrease relapse rates in people with opioid use disorder.
So now we get to what is probably the good news of the story, opioid-related harms. And here there's been a series of scholarly papers that have made it into the press because of the significance of the findings that basically suggest that medical cannabis policies and a few, they're starting to look at recreational policies, are actually associated with reductions in opioid-related mortality. There is no evidence, however, that availability of medical cannabis or recreational cannabis impacts mortality related to heroin and synthetic fentanyl. Why is that important? I'll come back to that in just a minute. But the studies that are looking at the effects of medical marijuana on opioid-related mortality find the effects overwhelmingly and significantly only on prescription opioids. It's not just mortality that seems to be negatively associated with the availability of marijuana. There's also reductions in fatal car accidents, opioid-involved fatal car accidents, and then treatment admissions, as well as hospital ED visits and admissions. So that's the good news. And that should have everybody jumping for joy, because if we're trying to stop approximately 50,000 deaths per year, 130 opioid deaths per day from happening every day, why not just go ahead and open the floodgates? And the reason, as I'm constantly reminded by a good colleague and friend of mine, Keith Humphreys, is that while these studies have been very important in showing a very significant association, there's a myriad of things that are also happening trying to tackle the opioid epidemic that are not always accounted for in these studies. So as much as we would like to say that this seems to be really valuable and really important for reducing opioid-related harm, and there is indeed an association, we cannot rule out yet the plausibility that some of this is due to these other opioid-related policies that are being enacted not just at the state level and the federal level, but within healthcare systems. Things like what was written up in Science by Jason Doctor, notices to doctors who have a patient that they care for die of an opioid-related mortality. They write a Dear Doctor note to these doctors, and all of a sudden they start decreasing the amount of opioids they're prescribing. Or a really cool nudge experiment that was done in a couple of different healthcare systems and being more broadly adopted, where the default in the medical Epic record, instead of prescribing 30 days of an opioid, the default is 7 days of an opioid. And just changing the default in the electronic record has impacted prescribing by physicians in healthcare systems adopting these policies. This is happening simultaneously with the advent and the growth of marijuana markets. And as scholars, we have to be careful to understand what is it that's driving these changes in mortality. I used to be feeling confident by the fact that we saw it in a variety of different data sets, claims data, and mortality, and hospital admissions, and geez, all of these, they're all telling the same story. That must mean that it's true. But then I'm reminded of the other things that are also happening in our efforts to tackle this opioid crisis that are happening simultaneously. Broad-scale distribution of naloxone overlaps with the opening of medical marijuana dispensaries, both of which should reduce opioid-related mortality. So, in summary, do we think that cannabis policy can significantly reduce the opioid epidemic as it exists today in terms of reducing the number of new initiates? Well, we know from prescription fills that actually new opioid prescriptions to naive users, people who have not had them in the past, have actually been declining, just like total prescriptions have been declining since 2010. So in essence, it seems like we're past the peak of new initiation in the dynamics of this epidemic. Yes, it is true that opioids might be helpful for some of the conditions where a new user might be introduced, but it's unlikely given the federal prohibition that the key doctors involved in the medical systems, the ER department, in the emergency situation are likely to say, oh, go home and take cannabis instead. Here's your prescription for your painkiller. And with all of this, it's important to also keep in mind that rates of heroin initiation are rising. Recently, it was the case that the vast majority of heroin users, the first-time heroin users, were people who were transitioning from prescription opioids. However, a few recent studies that are taking a more careful look and trying to understand the geographic differences in the opioid epidemic have found that users in places like Seattle and San Diego were much more likely to have initiated heroin, having first initiated a prescription opioid, than people on the East Coast. In the East Coast, 77% of people who are using heroin initiated with a prescription opioid. It's around 44% for San Diego and somewhere in the middle for Seattle. So there's important differences to help us understand it. And the question then is cannabis going to be the answer for stopping somebody from using heroin? Possibly, in light of the study that was just referenced here today, but we need a lot more work. So it's unlikely, in my assessment, again, I want to attribute it to Ziva, that this is going to tackle new use. What about misuse? Here I think it's a lot more plausible, because a lot of the opioid-related mortality that occurs because of sustained use of an opioid. And if cannabis is effective at reducing the length of time that someone is using an opioid, because it is as effective or more effective when used with lower doses of an opioid at misuse, then there's hope that it could be effective. Rates of prescription opioid misuse, according to the household survey, are already seem to stabilize. So this stock of users has already seemed to be stabilizing. So at this point, with marijuana as available as it is. And the rates of transition into heroin use and injection drug use seem to still be rising. So that's a problem. Because while cannabis might be effective at misusing opioids, prescription opioids, the evidence suggesting that it's effective at reducing the transitions to heroin haven't been carefully studied yet, except for with the young users. We need a lot more work there. And why is that so important? Because mortality today is being driven by the illicit heroin and fentanyl in the markets. The opioid epidemic today has significantly transitioned into an epidemic of the black market. So medical cannabis has been available in many places, and this transition has continued to occur. That doesn't mean that it can't solve the problem. It's just there's good cause to question the ability of it doing so. And there's the question of whether or not it can be effective with dependent users. And here we've had a slight stabilization, and we hope, according to household data, and the number of people who meet DSM-4 criteria for it. But there's no clear evidence yet that cannabis is a more effective treatment of opioid dependence than currently available pharmaceutical drugs that we don't have adequate access to and are pushing hard to gain access to. So, while I think that cannabis legalization may be an effective strategy for reducing some of the harms associated with the opioid epidemic, and some is good, I'm not saying that's bad, I don't think it's the silver bullet. I don't think it can be the silver bullet just because of the nature of the dynamics of the opioid epidemic as it has been evolving. And the fact that our science doesn't tell us conclusively that it will work. And in light of clear scientific evidence that it is the silver bullet, if there was clear evidence, I'd jump right on it. I have a family member addicted to opioids. It's a personal issue to me. That said, There are effective medications out there, and I would hate to see a policy debate about a potential possibly maybe drug take over the dissemination of drugs that we know to be effective at tackling this problem. Let's have a discussion about the benefits of cannabis, but let's not mix it up with the opioid crisis. Thanks.
Thank you so much. That was a great presentation, and I'm sure the next time I get assigned a story on this subject, I'll be calling one or both of you. So if folks want to ask questions, and I'm sure there will be some on this hot topic, we have the microphone right here if you want to come down and line up and take a few questions. Thanks.
My name is Barbara Herbert. I do addiction medicine. My best understanding of the current mortality data on people who are mortality data on synthetic opioids is that a large number of people have other substances on board at the same time. Many of them including benzodiazepines and other sedating medications. Do you see a role for cannabis in replacing those kinds of medication as a harm reduction to reduce mortality?
Yeah, I think that's a great question, and one that Susan Weiss raised to me a couple years back, is that benzodiazepine mixed with opioids is really what's deeply fatal for a user, and that cannabis is actually used as a replacement to benzodiazepine, and that might help reduce overdoses. I think it's an important thing to study. I have not yet seen a study that has tackled that yet. So I think it's entirely plausible, and it's worth researching, yes.
Anyone else have a question? Okay, we've got something.
No, I just wanted to ask if you wanted to say anything about the other story that's out there, that exposure to cannabis leads to a greater likelihood of either risky use of opioids or subsequent use of opioids, because I think, certainly you hear both sides, and I think you can't completely dismiss that either. There's animal research that suggests that that's a possibility, but I think it has to be also part of the conversation.
Thank you, Susan. Thank you for pointing this out. So what we showed was epidemiological data that helps to support the association between cannabis use and reduction of opioid use. But there are certainly excellent peer-reviewed articles that have demonstrated that cannabis use can lead to opioid use, or cannabis use is associated with later opioid use and abuse. I won't say lead to, but it is associated with later opioid use. And there was an Australian study that came out. It was a 4-year longitudinal study that tracked chronic pain patients who were on opioids and looked at medical cannabis users versus placebo. And the medical cannabis users did not show a decrease in opioid reduction and showed increased pain. So there are definitely, there's definitely data that speak to both sides of these stories when we look at epidemiological data. And I'll just say that that demonstrates the real importance of doing double-blind randomized controlled studies to actually pinpoint the potential efficacy of cannabis and cannabinoids to helping along all these steps of this opioid process, from the initial users to the people that are misusing the opioids, the people that are dependent. We really need good randomized controlled trials to be able to disentangle what we're seeing in the epidemiological and observational studies.
And I'm about to give away my next research paper to anybody who can beat me to it in the room, because I think it needs to get done. I mentioned this conundrum between the claims data that's showing a reduction in prescription opioids in states that have adopted medical marijuana policies and even recreational policies, and Yuyen's probably going to do this paper in 30 seconds after I say it. There's also a very interesting paper by Ellen Mura and her colleagues at Dartmouth published in Health Affairs just last year, talking about the impact of the redaction that occurred starting in 2013 that applied to all Medicare and Medicaid claims data. Right now, all the studies that we have in the claims data showing a reduction in opioids prescribed in medical marijuana states cover the years in which CMS separated and took out from files that data analysts could use conditions when someone also had a mental health or addiction disorder for confidentiality reasons. As Ellen Mira says in her Health Affairs paper in 2013, there's an enormous drop in the number of cases in the Medicare and Medicaid's claims data for hepatitis C, liver disease, depression, anxiety, mood disorders. Any of these sound familiar? Same conditions, chronic pain in the case of liver disease. When you're dying and when your organs are failing, it's a very painful process. These are conditions that marijuana has been prescribed for and are the same conditions that Bradford and Bradford use in their identification of conditions that are most likely to be influenced by the medical marijuana law. And they're absolutely right. Their study was absolutely done brilliantly, except for claims were being affected that we were getting as researchers because of comorbidity with addiction. That policy didn't get changed until 2017, and we still don't have access to the redacted data to know if these findings are in fact real or if they're the artifact of missing data. The fact that we see nothing in the prescription distribution as indicated by the DEA is what gives me cause and concern that the findings that we've seen on claims data in Medicare and Medicaid, both impacted by the redaction from 2013 to 2017, could in fact be an artifact. So please beat me to that paper.
Thank you for your insightful thoughts and presentation. I was just wondering, in the confounders that you outlined, there were a few things, but you didn't mention, to my knowledge, socioeconomic inequality. And I was wondering if any of the papers that you reviewed, or if is this part of your analysis? Socioeconomic inequality, it seems to be a big driver of mortality and morbidity generally, related to substances. So I was wondering if any of the paper that you reviewed was analyzing this as a confounder, a possible confounder, and if you thought any of this to be related to the opioid crisis. Thank you.
So there's been a lot of work about the deaths of despair and the impact of local unemployment and poor social economic situations and opioid-related mortality, and they've shown this in a number of different ways. Chris Room just published a paper in the Journal of Health Economics where he tears apart the argument that this is largely an economic phenomenon and says that it's actually could be described by illicit drug markets. Now, for those of you who study illicit drug markets know, those are likely to emerge in areas where there's economic poverty because it's one of the few ways to make a buck when you can't get a job. So that doesn't eliminate the role. In fact, it might give us the mechanism for it. But deaths of despair are highly correlated, the mortality is highly correlated with these socioeconomic factors. The question is, how does medical cannabis fit into that in my mind? I mean, we're still trying to understand what the drivers are for the deaths of despair. Chris Room has a plausible theory that makes sense to me, but still needs to be replicated and further assessed. The extent to which medical cannabis or recreational cannabis can solve that problem, to me, is a question mark. It's never been part of the full careful assessment. I mean, we've put in models, medical marijuana, rates of unemployment, other socio-disparities, and we focus on the findings of the medical marijuana and ignore the rest of the coefficients that also matter. It's not eliminating it. It's not describing all of it, is all I can say.
We're going to get to our last two questions. Actually, if I could, I just wanted to interject with a question of my own. You had mentioned this problem of essentially the media narrative getting ahead of the facts when it comes to the impact of medical cannabis availability and the opioid crisis. I just wonder if you have any thoughts on what went wrong there and what people on both sides of that conversation can do better in the future. I feel and hear your frustration about the conversation turning away from perhaps things that could make a more immediate difference.
Yeah, I have to say I was very upset when I got called by the New York director of the Addiction Society in New York, who said that my study was being used to have opioid dependence being added as a condition for medical marijuana in New York State, because my study clearly showed that it was useful for that. To which I thought, God, I hope they have better researchers than that. Why weren't they reading her studies? I am annoyed because I think there is a genuine desire, all of us would like to figure out how to stop this crisis so it stops affecting our current loved ones and the ones that we know are likely to be impacted. We're always looking for a silver bullet. There has been nothing in the study of addiction or in the study of drug markets or the study of most problems related to chronic diseases and health that a silver bullet solves the problem. So I feel like advocates who want to make a case for their cause use it as a silver bullet. And I get annoyed when people believe there's a silver bullet. If there was a silver bullet, I don't think we would have had the opioid crisis developed for 20 years. And cannabis has been available in California for at least that long. So.
And I just wondered though, what do you think people in both the press and people in the scientific community can do to prevent sort of misleading narratives like that from emerging in the future? Is this just purely on the shoulders of reporters who need to be more diligent and ask better questions, or is there a communication gap potentially on both sides?
We should stop tweeting.
No, I think that, I think there does seem to be a disconnect between the media reports and the science with respect to how nuanced the data are. And I think as scientists also, we want to make our findings as accessible as possible to the lay audience. And in some respect, we're at fault for that too. But we have to be very careful about the words that we use. We have to be very careful to talk about associations and not causation. And we have to be very careful about who we're reaching with these messages. And it would be great if we can convey the complexities of these data. Even the randomized controlled trials, they're very complex, and there is several limitations and several caveats that are necessary to be raised. And I can say that, if there are limitations and caveats to your study, those limitations are not going to be the highlight of the journal article in the Wall Street Journal. We're not going to pay attention to those limitations, but they're really important in understanding the complexity of the data.
Thanks. Let's take our last two audience questions here. Thank you.
Yeah, thanks. Great question, because it leads to another question. It's connected to the question I have, which is, we always talk about cannabis and cannabinoids, and we know that cannabis has at least over 100 different cannabinoids. And cannabinoids, most of the studies that used cannabinoids used a CB1 receptor agonist for the most part. So I wonder, and that speaks to this overgeneralization, in the media you always see a headline, cannabis cures cancer, and then you read the actual text and it says, a CB1 receptor agonist in rats was shown to decrease tumors, specific tumors that humans would never have. So I just wonder if, but the takeaway is cannabis cures cancer, right? That's what you remember. So
Alzheimer's, Parkinson's.
Everything. So I just wonder if there's anything that, when we have these conversations about cannabis and cannabinoids and the opioid crisis, whether there's nuances that need to be inserted in there about what kind of cannabis. You go to a dispensary and you have everything under the sun. Which one of those products it can potentially help with an opioid use disorder or the opioid crisis.
So Hanan just brought up a point about, when we're talking about cannabis, what are we talking about? When we're talking about cannabinoids, what are we talking about? And so I lump these things together, and and I'm definitely at fault for doing this because there's no such thing as cannabis. What are we we heard about hemp today. We heard about different concentrations of THC in different cannabis products that are in dispensaries. We talked about people using suppositories. We talked about creams, oral administration, tinctures, vape pens. So what is it that we're talking about when we see this in the media or when we report our scientific findings? And this is critical. This is critical to the conversation. And if we had another hour, this definitely would have been a highlighted point. So the truth is that what do we know about cannabidiol? Everybody is very excited about cannabidiol because it's not intoxicating. And there's evidence in the preclinical literature and in cell studies that it might have some therapeutic potential in cell models and animal models of disease. We know very little about its effects based on randomized controlled trials in humans, apart from pediatric seizure disorders, and a couple of studies looking at its effects for psychosis in people using it as an adjunct therapy. We know very little about cannabidiol. At this point, we know a lot about THC, and yes, it's intoxicating, but we have learned a lot based on the randomized controlled trials, based on its use in animal studies. We have learned a lot about what it's capable of. And we have miles to go. There are over 110 unique chemical components of the cannabis plant. We know very little, if nothing, about a handful, about more than a handful of those. And then we also hear about the terpenes, creating this entourage effect, right? What is this entourage effect? Is it real? Is it not real? We don't know. We don't know. And there's some data here and there that hints to the importance of including terpenes with the THC and cannabidiol to provide a therapeutic effect. This has not been tested in humans. There are hypotheses that are born from some strong preclinical evidence that really needs to be built on in the human laboratory and clinical studies. So, Hanan, thank you for pointing out the incredibly complex world of cannabis and cannabinoids.
And I could say the same thing on the observational side, but before I do so, I want to highlight a point. Ziva, how common is it for something to work beautifully on animals and on rats that fail to work on humans? Is that common? I mean, why shouldn't we be excited if we're hearing about the good studies on the rats?
Well, but they are, I just want to say that preclinical studies and epidemiological reports are really informative, and they help us to direct our clinical studies. So they are really important. Yes, sometimes the results in animal studies don't pan out, but they're really fundamental to help guide our research. But yes, it's good.
I won't go to the whole point of, just like in the lab, we don't know, we have no clue observationally, and I'm thrilled to hear that Jillian Shower's got Burfus adopting better measers of different types of products being consumed so that we will soon have better data. Average potency of these products we can use because we still don't know exactly which ones they're buying, so it's going to take us a little while before we have the answers to these questions. And while it would be great to have all this figured out in a year when they want to know what regulations we should be pushing on Capitol Hill, it's going to take a lot more than that to get the answers we need.
Ditto what he said. That's all I was going to ask, because it's like every time we hear about these studies, it's always a conflation of THC and CBD. It's like they're talking about CBD, but everybody thinks they're talking about THC or just the whole plant in general, when all you used was that one cannabinoid. So is it upon us to make sure people understand that? Is it upon you, or is it upon him?
So we as scientists are trying to learn what we're examining. I am thrilled that we're stopping to say, do you use marijuana or do you use cannabis in the survey? That is not a useful question. Let's stop with that question. We'll keep it as one so we have some sort of trend data, but let's stop focusing our analysis on that. We've got scientists paying attention. We're past the stage of just saying no. We want to know what this product is. But The product is evolving. So the information we get on the product that we were able to study 2 years ago is no longer the most commonly purchased product in the market anymore. What do we do about that? We as scientists have to be careful and say, we studied this on this type of product. Well, those are the details that don't make it into the headline and often don't make it into the quote, and often get absorbed by either side of the advocacy group that says, see, it's good, or see, it's bad. The scientific field, when we talk to regulators, when we talk to legislators, we do try to be honest on what we know. But we're always behind here because this is an area of policy where the policy moves at a more rapid pace than the science has.
I just want to say on a positive note, it is striking to me how information hungry people are about cannabis and cannabinoids. And now journalists, when they call, they are starting to ask these questions. Where did the THC come from? Was it plant-derived? Was it pet-derived cannabidiol? Or was it, marijuana-derived right? And so people are becoming more savvy about this, and it's happening at a really fast rate, actually. So I think that people are coming up to, yeah. So I think I have found that people are a lot more educated these days. People know that you can't just call cannabis indica or sativa, and don't use the word strain. I mean, like it's out there. Like these bits of information are definitely permeating. So it is an exciting time.
We need journal editors to become aware of those things, though, too.
We're working on it. All right, thanks so much. Let's give them another hand. So since reality is not getting any simpler, our conversations are going to need to get more nuanced.